All right, we'll go ahead and get started. Good evening, everyone, and welcome to our bariatric surgery webinar. My name is Angie Bunkley. I am our bariatric surgery program coordinator here at Tallahassee Memorial. We've got lots of great information for you tonight. I have two speakers. We have Dr. James Parker, who is a fellowship-trained bariatric and general surgeon with Tallahassee Memorial. We also have Mr. Greg Laffitte. He is a bariatric PA who specializes in the treatment of obesity. Wanted to let you know, just feel free to type in any questions in the Q&A or the chat. We will get to those at the end. We're going to have lots of time left over for any questions you may have. We'll get to as many of them as possible. Thank you all for joining us tonight. I hope you get lots of information. I'm going to go ahead and hand it over to Greg.
Okay, I think we're ready to go. Well, good evening, everybody. I'm pleased that you're here with us. This is an opportunity for you, I think, to hear some extremely important information. It's extremely meaningful, if you will. And I want to basically start this up with a question of the audience that's there. And it's going to be kind of very, very basic. And it's describing your clinical, how you feel about yourself now, your level of health, your level of fitness, your happiness, if you will. And are you better off today than you were, say, 5 years, maybe 10 years, 15 years ago? Or maybe would this be something that you could say that you've struggled with your entire life? And the part that's been the most frustrating for you is that no matter what you've tried to do to become healthy and have a healthy weight loss process, that you've not experienced success. And if the answer to those questions is that, yes, I need some help, you're in the right place. So good evening to you. We're going to start and get into the world of bariatric surgery. So here we go. Okay. A lot of information I'm going to pass tonight. It's going to be on the screen in front of you. And what I'd like for you to do, if you don't mind, is get comfortable. You might even get a pencil. If there's somebody in the family that needs to hear this as well, tell them, let's get involved with this together, because a full set of ears, 4 people or 4 ears rather, would be much more effective in terms of kind of remembering what we're going to go do. We're going to go about the team that we have here. I'm going to talk about the actual definition of obesity. It's an important concept that many of you probably have never heard of. Talk about the costs associated with this, surgical options, of course, benefits of surgery, and then, of course, most importantly, what are we going to do next? So here we go. The team. In this building at the Bariatric Center, we've got a bariatrician, that's me. We have a medical director. We have another nurse practitioner. That's what we do 24/7, 365 days a week. We specialize in this. We have dietitians that are outstanding. We've got nurses, behavioral therapists, of course, exercise physiologist over at Premier that I'll send you to. And then, of course, we've got our bariatric surgeons. So the team is multidisciplinary, and each of the services that we provide complements. We overlap. The doctor, the nurse practitioner, the PA, we specialize in treating obesity. And I think that it's extremely important to point out that we do this as a day-to-day, not on an occasion. And I've been here now, this coming May will have been 9 years. And I think my number probably somewhere is between 8,000 and 9,000 patients. So I specialize in this and try to stay current with the most recent medications, the therapies, the concepts, to have a good appreciation to making sure we provide you a standard of care to take care of the very best we can. We can do medical, we can do non-surgical, we can also focus on the surgery, of course, but it depends basically what your needs are. So a bariatric physician, bariatrician, they're one and the same. These are the bariatricians on our staff. Dr. Kane, there's the medical director. Dr. Judy Lewis, there's me, and there's Kim Dressel, one of our new nurse practitioners that are here. Mark Twain once said, if you could find an occupation to do on a day-to-day basis, you'll never work another day in your life. And everybody in this building that works towards this end, we love what we do. And I think we get good results, and we take care of you. The support team behind this, excuse me, exercise physiologist, excuse me, dietitians, and then of course our therapists. So we've got people that we communicate with on a regular basis. There's the surgical team. Dr. Gerard's there at the top left. Dr. Parker, who you're going to meet in a few minutes. Megan Bell's the PA over there in the surgery practice. And then we, of course, have got Angie, who you've been hearing tonight. And she's in charge of all things that have to do with the support of this. And she's basically the person that makes sure that all these delivery of services comes together without any hiccups. All right. Excuse me. What can we do for you? What can we do for you? What can this team do for you before you have surgery? When you come in, when you have the referral to come to this office, we're going to put your name into our computer. I'm going to have access to your medical file. And within the first 2 to 3 minutes, actually, I'll back up a little bit. Before the day begins, I come in fairly early and I read everybody's notes already to have a little bit of a sense of what their history is. I'm looking at metabolic or medical causes of obesity. You would say, well, metabolic. Well, I'd love for you to think about, I've done everything I can to lose weight. I've had lab work that's been done. I've been seen by a variety of people. I've been to maybe a couple clinics, and I can't find a way to satisfactorily lose weight in a healthy manner. Well, there may be a metabolic disorder behind the scenes. That's my job. That's our staff's job to figure this out. Therapists, when you get to meet with them, there might be some emotional connection to some of the eating habits that you have. And that conversation is extremely helpful because sometimes you may see some things that you really didn't know were there. We look at medications. Some meds can prevent weight loss. Some of the medications might have contraindications for something that I might choose to use. So we're going to look at this and be very professional about it and basically peel back every onion and flip every page to make sure that we know what we're dealing with. Lab work goes without saying. I have to have current lab work. We love to help people understand that there are some behaviors that you might need to engage in and to change, and gently we will prod you to work on those things. The dietitians are excellent in their field to help you understand nutritional habits, the quality of the foods that you might eat, the things that you might need to do that would be better, and they'll give you a really, really good education with regard to micronutrients, things to do before the surgery and things to do post-surgery so that we can have you in the very, very best physical state to have that great outcome when you get done with this 3, 4, or 5 years down the road. After surgery, of course, you're going to follow up with your surgeon. But when they get done with you, you're over here, and our team's going to help you to stay accountable. Excuse me. The more support that you can get, the likelihood of your long-term success goes up exponentially. I love to be able to say, what did your dietitian say? And you will be able to tell me back what they have advised you to do. We love to be able to have lab work to be able to illustrate that as you become more healthy, as you lose this weight that's not healthy to you, we begin to see some improvement on things like the CBC, the CMP, if you will, cholesterol status. So we love to monitor things so that we can help you when you get done at each of your visits to walk out with kind of a sense of accomplishment, to know that what you're working towards is producing those desired results. So everyone in the room there that's watching this right now, I want you to focus on what I'm going to say in the next couple of seconds. Obesity, ones at one time used to be thought of, well, that person has caused this. They are responsible for a degree of behaviors or attitudes that are solely their responsibility. Well, the years that have gone by, we've been able to dispute that. And I want you to understand where we come from is I want you to appreciate that we recognize obesity as a chronic disease. Chronic disease. I didn't say it was a failed behavior. It's a chronic disease. Body fat goes up, which creates significant number of challenges. The picture there, you can read each of those small bullets will explain maybe some of the kinds of things that you may be experiencing that we can address to be able to help and to change over time. The definition. This is important because your insurance company, whether you are Capital Health Plan, Blue Cross Blue Shield, whether you are maybe a TRICARE, variety of plans that are out there generally will share these concerns. We look at the definition of obesity as that as a person with a body mass index greater than or equal to 30 kilograms considered to have obesity. And if we look into the numbers at the bottom of the page there, BMI 30, 34.9, that's a class 1, there's a class 2, there's a class 3, and so on. We discuss that when you come in person and try to give you a little bit of a sense in terms of the journey, in terms of the goal of where we'd like to end up. Because I've been doing this job so long, I've come across countless stories where people, men, women, have come in and they've had emotional, when I ask the questions to try to understand where they've been, emotionally, it can be very draining for them. And because that, chances are they've been made to feel bad. They've made to feel weak, or that they were a failure, they were lazy. In the past, the thought was that obesity was the cause of a weakness or the failure for a person not to do what they were supposed to do. You can work your way out of this. You can lift weights, you can run, you can do something that you were not doing before. And weight loss surgery, included in some of these perceptions, was viewed as dangerous. In some communities, that might still be present, but you won't find that experience here. So we see it from our perspective, it's this disease, and at the very root cause, it leads to many additional serious health conditions. And it's our experience that surgery is an extremely effective and safe tool for healthy weight loss. So I'll back on this one more time. Before, it used to be the perception that it was more of the individuals were causing this. Now we look at this and say, no, it's a disease. Now, granted, there may be some behaviors which need to be changed. There may be some circumstances out there where medications are causing a difficulty for you to be able to lose weight. That's our job, to be able to work through this and to figure it out and to advise you when you come here. Many people have a perception of, well, I'm obese. What I see in my obesity is what I see in the mirror. It's important to have an appreciation for that. What you're seeing in the mirror, think of this more of a gland. Fat is an actual endocrine gland. And quite frankly, it's the largest gland that's in your body. And the gland characteristics of this are it's extremely important to appreciate the fact that it causes and produces hormones, inflammatory factors. And those factors of the hormones can lead to such as you see, heart attacks, the strokes, diabetes, joint pain, and inflammation. So it's not just what you see in the mirror. Why we do lab results, why lab evaluations. And when we begin to bring down this unhealthy fat, we can see that we can have a very significant and profound effect clinically on that risk associated with the heart attack, the stroke, the diabetes. So it's extremely important that in this journey, and as I mentioned at the start of this, you're here tonight to say, I've done everything that I can. I'm afraid of the health concerns I've seen in my parents. I want to do something. You've tried medications, injections, tried the gym. That's why we're having the conversation tonight about the obesity. There are some factors out there that maybe you really can't control. I mean, we can't pick our parents, obviously, but genetics can make up a little bit of a, it has a degree of relevance to it, relevance, if you will. Ethnicity, of course. If you have medical causes and diseases, the first thing that always comes to mind for me is if you are a diabetic, you're more than likely struggling with your weight, especially if you've been put on insulin. Hormonal influences are significantly important. Think about the hormone changes that are associated with women in postpartum, childbirth, or as you get a little bit older. What about menopause? Circumstances such example, hypothyroidism, stress. I remember a number of people describing gaining weight back in the year 2020 when they were working at home, and there was a lot of additional caloric intake as a result of staying at home, not being out like you would ordinarily do. We all remember what that was like. Lack of physical activity. The bulk of the workforce today is not involved in physical labor outside. We sit at keyboards now. Never mind the fact, environment. In a car, you go everywhere. Most people don't walk. So a number of circumstances that are of concern that are associated with the obesity. Now, each of you tonight will look at this list in front of you and you'll be reminded, yeah, I have diabetes. I see sleep apnea. I see depression, high cholesterol. When you have these concerns in your medical chart, you must consider that obesity is contributing to this. And if you've done everything that you can without the outcome that you had been hoping for, you're in the right place tonight, because obesity is associated with every one of those that are on that list. And I can say, not because I'm reading this from a book, excuse me, that in my experience, I have seen every one of these improved. Some go away or some go more formally into what we call remission. And you think about, if it goes into remission, that means maybe I don't have to spend the money on this medication or that treatment. So the medical problems are real. Obesity is a huge role and a contributor to that. Sometimes people feel embarrassed about this, or they don't want to come and talk about it. There's a stigma, if you will. But the reality of it is 42% of folks in the country today are obese. And the 9.2 number is the highest incidence of this. When you come in and we bring you into our setting in this building, we're going to take good care to protect your emotions and have you walk out of here feeling like, all right, they understand what I'm up against. And that's what we do on a day-to-day basis. That's why you're here tonight. Now, that's a big number, 100 million adults, and getting larger. The number is growing. I'm kind of amazed by the simple fact that you can order a pizza off your phone. You can have somebody show up with it in a matter of seconds. Access to food, processed food, lack of activity overall, and the heightened stress that everybody seems to be experiencing in these days, it's affecting a number of people. And food is a legal addiction. So worldwide, a big concern. As I get towards the end of getting ready to turn this over to Dr. Parker, I really want to focus on goals. This is what we're here for. That's why you're here tonight. The adult patient that's overweight or with obesity, bottom left corner, improve your health. Absolutely. Definitely need to improve your health. I want to get rid of the diabetes. I want to get rid of the high cholesterol. I'd like to get rid of triglyceride challenges. What about the middle one? Improve the quality of life. I saw several patients today, and they were here today. They need to lose the weight, excuse me, in order to undergo knee replacement. They have to get a BMI under 40 in order to undergo knee replacement, which significantly will improve their quality of life because they can get rid of the cane, they can get rid of the walker. They then increase their mobility. They then increase their capacity to play with their grandchildren or to play with their kids. So we improve patient health, quality of life, and then improve the body weight and composition. The goal that we have here is summarized that if I can help you improve and get to a healthy weight with the healthy weight loss, it's not a matter of just losing weight. We have to consider and focus on the fact, excuse me, that you have to lose the correct weight. And we're going to do a body composition analysis on you periodically for comparison, so that when we see you in January of this year, when 6 months goes by and we see weight coming off, you'll be able to use a document that we can then advise, oh, you're doing a good job here. We all certainly will do this after the surgical recovery period of time. So body composition is a big deal. So our management goals, improve body weight composition, get you healthy, get you happy, and get you active. Now, as long as I've been here, I can tell you that I have seen circumstances that would be, I suppose, the best summarization that I can offer when I hear people say, how do you feel about this? Is that the patients invariably will say, I wish I had done this 10 years ago. So how much can bariatric surgery help? Okay. It's an effective therapy for weight loss. Dr. Gerard has even said it's the single medical experience that actually reduces mortality. So this is an effective therapy for weight loss, and the weight loss can result in the improvement of the complete resolution of those comorbidities. And the number 70%. Now, this is a big deal. And to do some math with this, 70% of their excess weight. So if you are 100 pounds overweight at about 18 months, a very, very conservative estimate is that you should be able to lose about 70 pounds. Now, that's a slide, but I'm the human that does this for practice, and I can back that up because I have seen it. This is real. This is clinical data. This is something that you can say, all right, I've got this team that's going to help me. So the bariatric surgery can make a great big difference, particularly because of the technique that the surgeons perform, the surgical procedures that they perform. Dr. Parker is going to address that here in just a few seconds. Okay. I need everyone that's listening to have a very, very serious conversation with your insurance company. Insurance companies sometimes move the goalpost. You need to make sure that your surgical benefits or the coverage is in writing in your policy. And you're going to be asking for things like, okay, am I a candidate? You want to make sure that your your insurance is going to cover it. You're going to have a BMI of greater than 35. You don't need to write this down tonight if you don't want to. It'd be good. BMI greater than 35 with comorbidities, or a BMI greater than 40 without. And I have a sheet of paper here that I just got that's from Capital Health Plan. It spells out what their policy is with this. So you need to be educated about what your insurance is going to do for you. You've got to be healthy enough to undergo a major operation. So I'm going to pause on that one just for a second. If there are requirements to get a pulmonary clearance or a cardiovascular clearance, those will be addressed by the surgeon's office. You have to be able to document, yes, I've tried. I've tried to lose weight since I was age 18. My weight gain has been profound. I've tried phentermine, I've tried Qsymia, I've tried topiramate, I've tried Contrave, and the list goes on. Absence of drug and alcohol problem. The therapist that we have here that you're going to see is going to consult with you with the door closed, and we'll have that conversation. Now, there may have been some things in the past, and understand we said the absence of this. If there's something that's ongoing, we can work with you. It's not an absolute contraindication. No uncontrolled psychological conditions. Consensus by a team, which we have, and then you'll understand the surgery and the risk that are associated with surgery. That'll be talked to by Dr. Parker. Now, must be dedicated to a lifestyle change and lifetime follow-up. I cannot overemphasize that. The surgery is an extremely, extremely powerful tool. The results that I have seen have been amazing. I have seen people, more than one person, lose over 200 pounds. Several just this week. The success stories are because they stayed with the office, they followed up, and they were dedicated to lifestyle change and follow-up. When that happens, we see fantastic results. Okay, so I've covered a lot of information, and now that comes to that point in time where Dr. Parker is going to step up and go into the detail here with regard to your surgical options. Here he is.
All right, everybody. Greg did an awesome job. I was in there for all of that, and I probably couldn't have presented that half as well as he did. So that's much appreciated. I'm Dr. Parker. I'm one of the bariatric surgeons at TMH, partnering with Dr. Gerard. They brought me in last November, so I've been here about 10 months, a few years out of fellowship at Kansas City, St. Luke's, doing bariatric surgery and other minimally invasive and robotic surgeries. So let's get into it. So let's talk about some surgical options that are available for weight loss. So they classify these, and historically they've tried so many different things, and we've kind of narrowed it down to two prominent surgeries that have just stood the test of time. The first one is the gastric sleeve, which is a restricted procedure. It's performed about 75 to 80% of the time. And basically what that does is just cuts down on the size of the stomach. So we remove about 80% of the stomach. As some people call it, stomach stapling, vertical banded gastroplasty, or sorry, vertical sleeve gastrectomy. But basically just take a staple line straight up the sleeve, decrease the size of the stomach, decrease the amount of food that you can eat at one time, and it has great weight loss. The other restrictive procedure is the gastric band. We used to do that. We don't do that anymore. So I take out bands. I don't place bands. And that was really taken over by the gastric sleeve about 10 years ago. And then there are the malabsorptive procedures. And so there's a biliopancreatic diversion with duodenal switch. We do not do this at TMH. It's a more advanced surgery. We are starting to consider this in the future, but it has very specific requirements, and usually requires patients who are having trouble with weight loss or reflux after a sleeve. And then there's the combination procedure, which is one of the oldest bariatric procedures that has stood the test of time, is the gastric bypass. And basically it's both restrictive in that we take away a majority of the stomach and connect that to the bowel, where it bypasses a significant portion of the bowel and prevents some of the absorption of a few of the calories. It also prevents absorption of some of the nutrients, which is why we require multivitamins for any of these procedures. And so kind of touched on this, but the gastric bypass, or the Roux-en-Y gastric bypass, and this is kind of how it works. And so if you see right here, I don't know if you can see my mouse pointer, but basically the pouch that we have is about a 50 ounce or a 50 cc 2-ounce pouch at the very top of the stomach. It removes the fundus of the stomach, which is the part of the stomach that creates appetite, that makes you hungry. And we connect the small portion of the stomach to the small bowel, which bypasses some of the proximal duodenum, which helps with some of the malabsorption, decreases some of the nutrient absorption. And so the food passes through this little channel right here, and then meets up with all the gastric juices, which help to break it down kind of later in the path. And so that's the bypass portion. The sleeve gastrectomy, like I talked about, we remove about 80% of the volume of the stomach by stapling straight up the stomach here. We remove the fundus, same as the bypass. It removes the ghrelin release, which is the part of the stomach that gives us a sensation of being hungry or appetite. And it also restricts the amount that you can take in at meals. And so this is the most frequently performed procedure. And most people prefer the sleeve gastrectomy to the bypass because it doesn't necessarily completely change the way that you experience food. You go out to dinner, you'll eat maybe a third of your portion that's served to you, as opposed to a bypass where you will eat, bites and then space those bites out over time. So these are some of the complications that you can have after bariatric surgery. Typically, bariatric surgery is well tolerated. The pain is very minimal with surgery. We do local blocks during our cases, which prevents postoperative pain for the most part, to where we haven't had to send patients home with pain medications in over 2 years. So some of the minor complications that can happen. The number one is atelectasis, which is basically just where the lungs just need a little bit of extra help to start breathing back to their full potential after surgery. A lot of that has to do with the fact that you just had surgery. This is a complication of any procedure. Reflux is one of the minor complications of a sleeve or GERD, gastroesophageal reflux disease. And 8 to 11% of patients will have worsened reflux after a sleeve gastrectomy. And so that's one of the main reasons that patients will get a bypass instead of a sleeve, would be if they have bad reflux that's not controlled with daily medication. Reflux is also related to obesity. So losing the weight can actually improve reflux in a majority of patients. And then other smaller or less significant complications would be wound infections in a sleeve are very rare. We have to remove the stomach from one of the small incisions that we make, and those rarely get infected. Marginal ulcers, 1.4%. It's just an ulceration of the stomach from acid because of the staple line. Some people get hypertensive crisis because of the anesthesia. They get DVTs because of blood clots, because of either predisposed clotting conditions or just the lack of mobility after surgery. And then major complications, you can see that these are much less after a sleeve gastrectomy. Some patients get strictures. The inflammation reaction to some of the surgical techniques can cause the stomach to tighten up, which can increase reflux, increase dysphagia, or difficulty taking food in. About 1 in 50 patients will experience this. Bleeding from the staple line, it's hard to predict who's going to get this. It's very rare, about 1 in 100 patients. Anastomotic leak, it's quoted here as 2.3%, but I don't think we've had a patient with a sleeve anastomotic leak at TMH, and I think, in the most recent literature is 1 in 300, so about 0.3% of patients. And then small bowel obstructions can happen after any surgery, and mortality is about 1 in 1,000. And typically that's due to either a severe pulmonary embolism from a DVT or anesthesia-related complications. And this is our specific TMH bariatric database, and this is covering the past couple of years. And this is so from September of 2022 to August of 2023, we performed about 140 sleeves and 60 bypasses. And so you can see our numbers are very good at TMH, and that has to do with the multidisciplinary team. Dr. Gerard was here during that time span. I can't take credit for these great numbers, but I think we'll see better or similar or better numbers, this upcoming year. So readmissions after bariatric surgery for 200 patients was only 10 or 5%. Only 1% of patients needed a reoperation. No bleeds, no bowel obstructions, few DVTs, 0 mortality. And so we've come a long way at TMH, and using this multidisciplinary approach, we've been able to almost eliminate complications, which is one of the biggest things that people are worried about when they're pursuing bariatric surgery is the risk involved. And I can tell you based on these numbers that risk is very low. And so now we're talking about long-term complications, and this is something that we typically see when patients are lost to follow-up. They're no longer taking their vitamins. They get back to their old eating habits. Some patients get protein malnutrition. This is more likely with gastric bypass. They're just not taking in enough proteins. And then the proteins that they do take in are bypassing the segments of bowel that are actually absorbing them. And this is fairly rare. And then vitamin deficiencies are more common after a gastric bypass. But if you're taking the bariatric multivitamins, you won't have any problems with this. There are a multitude of different vitamins. There are big pill vitamins. There are gummy vitamins, which also need iron to be supplemented on top of that. But this is something that the nutritionist can go through with you. So now talking about expected weight loss. We have pretty similar expected weight loss with sleeve and with bypass. We used to think that bypass was superior to sleeve in weight loss, but we've seen recently that they're very similar. And we're talking about excess body weight loss here. So as Greg mentioned, if you're 100 pounds overweight, and then we're talking about the number of pounds you would lose if you were exactly 100 pounds overweight. So at 3 months after surgery, 40% excess body weight loss. I think typically I see around 18 to 20% overall total weight loss at that time, which is at 3 months almost equivalent to some of the bariatric injections and medications that we see. At 6 months, you're looking at about 60% excess body weight loss, or 60 pounds if you're 100 pounds overweight. And then at 12 months, it's about 70% excess body weight loss. And nationally, this is the average that you'll maintain long-term for weight loss. Now, I tell all of my patients that this is just an average. This is based off of hundreds of thousands of patients across the country. And we're talking about motivated patients, not motivated patients, good surgeons, not great surgeons. And so with a good surgeon and a motivated patient, you can exceed these numbers. And I think you'd have great success. So losing weight can help your body function better and improve your ability to do the things that are important to you. And here are just a few things: just walking around the neighborhood, taking the stairs instead of the elevator, stretching, getting back in the gym, like Greg was mentioning earlier, playing with your grandkids. I mean, all of these things can be improved by losing weight and be more enjoyable. And so as far as results, bariatric surgery has been proven to reduce those comorbidities that were mentioned earlier. 75% of patients come off of their CPAP, and most of those are within the first couple of months. 92% of patients come off of their blood pressure medications within the first couple of months. 95% of patients are no longer diabetics after their surgery. 97% of patients no longer have high cholesterol. It's amazing the response that the body has to bariatric surgery. And I don't think we fully understand why things improve so quickly, because the weight doesn't fall off just like that. But I think that there is some sort of hormonal response where the body decides that it's cured almost. And if I had the answer to that, I wouldn't, I'd still be sitting here. But I think that could, cure a lot of the disease in the world. So surgery can help change your life. It improves or resolves obesity related illnesses. And there is a 90% reduction in 5-year mortality, and that data came out recently. It reduces healthcare utilization and direct healthcare costs. The price for surgery, and we talk to insurance companies all the time about this, the price of surgery is about the price of 1 year worth of GLP-1s. When you stop GLP-1s, the weight comes back. When you get surgery and you stick with the program for the rest of your life, the weight does not come back. It reduces or it improves quality of life in about 95% of patients. Most patients have great success with surgery. Obviously, there are, hiccups that can come with any surgery. And when those happen, you have an entire team here to help you work through it. So remember, surgery is a tool that requires a strong commitment to lifestyle change and a lifetime of follow-up. So common aspects of bariatric surgery at TMH, it's all done with minimally invasive techniques. And since I've been here, we've 100% performed these surgeries robotically. I'm a strong believer in the robot. I think we have great outcomes because we've embraced the robot totally at TMH. All surgeries are typically done in under 2 hours of surgery time. And sleeves are finished in, about 30 to 45 minutes. The hospital stays between 1 to 2 nights. Our average stay is between 1 and 1.2 days. And that extra day is usually with sleeves, and it's with a significant nausea, but we've actually been able to decrease stay to where I can't tell you a single patient that I've had so far that stayed more than 1 night. Everybody's up sitting in a chair, walking around the hallways the day after surgery, and they're asking me to go home. And most patients are back to work in 1 to 2 weeks. And typically that 1 to 2 weeks isn't because patients don't feel like working, it's because they're just trying to adjust to the new health standards that they've signed up for by getting the surgery. And so they just want to be ready to, hit the ground running when they get back to work. So for insurance information, I'm not an expert on this at all, but we have people in our office who are. The requirements for approval depends on the policy. And unfortunately, that's a big issue in Tallahassee specifically, which is crazy. And it's something that we're working on. Most insurance companies require a BMI of greater than 40 or greater than 35 with comorbidities. There's some new data that's actually coming out of Orlando that's pushing that down even 5 BMI, BMI greater than 35 or 30 with comorbidities, but we're not there yet for approval nationwide. Documented history of medical weight loss attempts, and this is just 3 to 6 months. And so once you start our program, you get that through the program. 5-year history of being overweight, psychological evaluations, nutritional counseling, it's all part of the package. And we're here to help you. We'll walk you through the process. We'll review your specific plan requirements. We'll help submit your documentation for insurance approval. We'll provide examples of documentation required by insurance. But we need you to help us as a team work together to get you through toward surgery. And so calling the insurance company, finding out what you're eligible for is important to make sure that we stay on pace and on track through the process. And I think Angie's going to take over here, but she's the best. If you have any questions or concerns, get in touch with Angie and she'll take care of you.
Thank you so much, Dr. Parker, and thank you, Greg. Please feel free to take down my information. That's my email address right there, my phone number. We're going to have time for questions and answers, and also we're going to do a fun little activity to win a Publix gift card. But if you think of questions afterwards or we don't get time to get to them tonight, please feel free to reach out to me. I'll be more than happy to get you an answer. So first of all, I want to do the drawing for the Publix gift card. I want to see who is paying attention. I've got a question. Please go to the chat and type your answer. We're going to try to catch the first person to answer as our winner. But who can tell me if obesity is a chronic disease? Yes or no? Is obesity a chronic disease? All right, looks like Dina. Looks like Dina was the first one, I think. Or Yomani. Macy, did you catch who was first?
I am seeing Imani as the first.
All right, congratulations. We will make sure that we get you an email and get up with you about getting your Publix gift card. Yes, obesity is a chronic disease. We'll go ahead and go into some questions. Feel free to type it in the Q&A, or if you want to utilize the chat. Our first one, I think we've already covered this one. It's a person that is 5'2" and 200 pounds, wants to know if they will qualify for the sleeve. When we went over the BMI and comorbidities, hopefully that answers that. If you don't know what your BMI is, there is a calculator online that you can use. Next, we have, if insurance doesn't cover the surgery, how much would it cost by itself? That one, we are currently revising our cash price for bariatric surgery. We are looking at trying to see if we can come up with a competitive price. And right now we're working on that, but please don't quote me on this. I don't know exactly, but I think it's somewhere around 20,000 currently. But again, we are working on that and looking to develop a more competitive cash price option. And I hope to have that available in the future. Next, we have, how do you determine the excess body weight according to a chart that is out there that shows, okay, how do you determine excess body weight? I'll let Dr. Parker take that one.
So excess body weight, there's a number that's, based on height for ideal body weight. So I guess for me, I'm a little over ideal body weight, but for a 6 foot tall male, ideal body weight would be somewhere around 185, 190. And so excess body weight is any poundage over top of that. And so if I weighed 290, I'd be 100 pounds excess body weight. And so that's how you calculate it. And you just have to Google the specific numbers. And then it also depends if you're male or female.
All right. We have, if we aren't approved by insurance, can we still get it ourselves? And I also have another question. Is there a payment plan for paying out of pocket? And unfortunately, the answer to that currently is not at this time. But again, it's something that we are looking into and trying to revise our cash price and see if that's an option. But currently, as of right now, I do not believe that that is available. Does anyone else have any other questions for either Dr. Parker or Greg? Okay, here we go. Had a lap band and informed it has slipped, do you still need to go through the protocol for insurance due to done with lap band?
I think that if you have a slipped lap band and you are symptomatic, you should come in and just talk to us and we can figure out your symptoms. If it's completely asymptomatic, it depends on insurance, bariatric surgery coverages. If it's symptomatic, it can, obviously something needs to be done about it. And there are, I won't say there are ways to get around it, but it becomes more of an acute issue. And it could be where, where the bariatric coverage isn't necessarily, doesn't matter anymore. So that'd be a very specific question. So if you come to clinic, we talk about it.
All right, next we have, Greg mentioned that he had a handout from Capital Health Plan. Did they recently change their policy? I don't know that it was recently changed. I think maybe it just was, it's something that was being enforced. And each person may have a different policy and may have different coverage levels. So you would really need to reach out to CHP directly, or one of our specialists could help you with that. But that would be a question for your specific plan with CHP as well. How long would you say the process is to get everything covered?
So typically when you get referred, I mean, honestly, if you just call Angie or email Angie, she can get you in to see me within the next couple of weeks. And if my clinic's busy, I'll get y'all fit in where we can. But to get things covered, usually what you'll have to do is you come in to see us. We refer you to the metabolic center. And you'll see bariatrician a couple of times, the dietitian a couple of times, the psychiatrist, and then you'll get sent back to us. So the whole process from starting the surgery process to getting insurance approval, and insurance requires 3 to 6 months. And so that whole process usually takes about 6 to 8 months. But I think I answered 2 questions by.
Yeah, it's just all.
Yeah.
So how quickly can you get in? We're, I can type in the chat Dr. Parker's office phone number so that you guys can have it if you want to call and make an appointment.
And just say you were in the webinar, and then they'll slot you in sometime next week if you want to.
We have another question here about when having PCOS, your weight gain, you gain weight rapidly. If you don't have, if you don't have an overweight period more than 5 years, does that mean we don't qualify for coverage?
I've honestly never seen that. That's new to me. And I actually have the CHP document in front of me. Greg left it, so I can skim through it and see. But honestly, that 5-year overweight period, I've never seen any insurance press on that. So I think it's just kind of one of their fine print rules, but it's never really enforced. But I can check on that.
Yeah, we have someone that says, please make sure to check your CHP policy. Absolutely. Not everyone has the same level of coverage. Some may have exclusions, some may not. So you would have to reach out directly for your specific plan.
And the CH policy I have in front of me, the criteria does not mention how long you've been overweight. So.
Do we have any other questions? We've got a few minutes left. It looks like that may be it for now. Again, if you think of any further questions, feel free to send me an email or give us a call. If you'd like to schedule a consult, we have Dr. Parker that you met here tonight. We also have Dr. Joey Gerard, and we have Mr. Greg here at our bariatric center if you're interested in non-surgical weight loss options. It's always a good idea to start out with a referral from your primary care physician. A lot of insurance companies require that, and that's the best starting point. But if anyone needs assistance with how to approach their insurance company and what questions to ask and things like that, I have some forms that I can email you to help with that process. Says, are the consultations free? No, that would be either a surgical consultation or a new patient appointment with Greg here at the Bariatric Center. Most of the time, those are covered under your insurance plan, but again, it's different for each person, but they're not free. And yes, I do believe I have everyone's email address that registered for the webinar, and I can do a follow-up email with forms and just a little bit further information. If you don't have a primary to get a referral, yes, that is okay. You would just give us a call and schedule an appointment. You're welcome. Oh, absolutely. Thank you all for joining us tonight. I hope that you got lots of information. Please reach out to us if you have further questions. If you'd like to schedule an appointment, we're here to take care of you guys. I guess we'll end on that note if there's no further questions. Thank you again.
Yeah, thanks for coming, everybody.